Hi, my name is Fred Heckler. I'm recording this at Allegheny General Hospital. This is going to be a lecture on examination of the hand. It's a talk I've given for well over 20 some odd years in various forms, and it was thought that it might be helpful to have this in the resident library for review. So I'm going to try to make a version of it that'll help you out maybe some night when you get called in to look at a hand in the emergency room in terms of how you approach it. Now, the reason we give the talk, and we try to do it early in the year, is that a lot of people find examination of the hand in the emergency room, particularly in the trauma setting, somewhat confusing, a little bit challenging. The anatomy is somewhat unfamiliar, and we have problems secondarily from that confusion with communication. And the communication I'm talking about is attendings like myself who are home at night, get phone calls from junior residents in the emergency room regarding a patient who's had a hand injury, and the description doesn't really allow us to make a rational judgment as to what the problem is, what we need to do about it. And there are ways to simplify this, make the communication more accurate, and standardize it a little bit, so I thought this might be helpful to you. Now, in terms of the hand itself, why the emphasis? Hand's a pretty important organ. It has a lot of functions. The primary function is grasp. However, it's got lots of secondary functions which are important. For example, it's a sensory organ. You can tell putting your fingers in your pocket whether you're touching a dime, a quarter, or a nickel without looking. Unusual. Blind people can read with a sensation on their hand. The hand has other functions. It's an organ of expression. You know when your mother did this to you, what she was talking about. You know when some guy does this to you, what they're intending. You know when that third finger is raised up, what it means if somebody drives by in the car honking. It's an organ of expression. It's a useful organ for other things, hopefully rarely. And loss of hand function is very important in the overall well-being of any patient. So we want to be able to diagnose what's wrong, and we want to be able to tell what we need to do about it simply and reliably and on a reproducible basis. So the first thing we want to talk about, therefore, is nomenclature. So we're going to use this little camera here so you can see my hand in the audience. This, of course, is a hand. And from the anatomic standpoint, we want to standardize what we're talking about. And the nomenclature I'll talk to you about is recognized by the International Societies for Surgery of the Hand on a universal basis as to what the proper way of discussing things is. So, when you look at a hand, this is proximal. This is distal. This side, however, is not medial or lateral, because it depends if you're looking at the hand this way, when what was medial a second ago no longer is. So the proper nomenclature for the laterality is the radial side, corresponding to where the radius is, and the ulnar side of the hand. And that also goes for the fingers. So in the index finger, this is the radial side, this is the ulnar side, not the medial or lateral side, again, because depending upon how you're examining, that can be exactly changed right over. So you don't have to worry about that if you simply use radial and ulnar. Now, in naming the digits, this is the thumb, this is the index, this by convention is the long, even if it's partially amputated and is no longer the long. This is the ring, this is the small. That is considered preferable to first, second, third, fourth, and fifth. Because, of course, if you have a patient who's had an amputation, is this now the second or is this still the third? So thumb, index, long, ring, small. Proximal, distal, radial side, ulnar side of each digit. Radial, ulnar side, ulnar side of the hand. This is the dorsal or extensor surface. Again, not the top, because it becomes the bottom when you're looking like this. This is the palmar or flexor surface. Dorsal, palmar, extensor. When you look at the hand, there are a number of topographical landmarks. You have 1, 2, 3 bones in all fingers except for the thumb. This is the distal phalanx from here to here. This is the middle phalanx. This is the proximal phalanx. And between them you have a joint. This is the DIP, distal interphalangeal, between two phalanges joint. This is the PIP, proximal interphalangeal joint. And this right here is the MP, metacarpal. This is the metacarpal bone, phalangeal joint. We're not going to talk about anything proximal to that today to speak of. So the DIP, the PIP, the MP, MP's back here. Now if you look at the palmar surface, the flexor surface, you see some creases going across each finger. 1, 2, there's one here, flexion creases, and there's one here. This one is the DIP flexion crease, or the distal flexion crease of the finger. Let me get that shadow off, there you go, right there. This is the PIP, or middle flexion crease. This proximal flexion crease, by the way, each of these corresponds to exactly where the joint is. There's the flexion crease, there's the joint. There's the flexion crease, there's the joint. So if you have a laceration there, it's important because it's very easy to be intra-articular within the joint at that point. But the proximal flexion crease of the finger, which is this, that, right across here, is not at the joint. If you look here, there's that joint, here's this joint, my finger's halfway between them. So that's a flexion crease. If you have a cut there, it doesn't get into a joint easily because there's no joint there. And the distal palmar flexion crease right here corresponds to the MP joint. See where my finger is? When I turn it, you can see it's right there. So distal flexion crease, middle flexion crease, proximal flexion crease, joint, joint, no joint, distal palmar crease, joint. See it right there? If you look a little more closely, and I'm going to zoom in a little bit. Whoop. Try to. Getting out of focus here instead of zooming. Oh, that's why I know why. We're fixed. Wrong button. There. Okay. Here's some more nomenclature. Fingernail. The eponychial fold is this little piece of skin right here. This white stuff is the lunula. Eponychial fold, lunula, and the paronychial fold on either side. So if you look at it on end, you can see that little fold here, here, and here. Eponychial fold, paronychial fold. So if you get an infection underneath that, it's paronychia. There's an eponychial infection, paronychial fold, okay? Lunula, and that means that the germinal matrix is just proximal to that, right under this skin here. And that's the root where all these nail cells grow up from. So injury here is much more significant than injury here or here. So that's the name. The skin out here is called the pulp, from here to here. This is the pulp of the fingertip. It's rigidly fastened to the bone by a bunch of fibrous septi that go from the skin to the bone, as opposed to this skin. You can see this is more mobile here than this is here for that reason. Zoom back out. There we go. This dorsal surface has skin on it that's a lot looser than the skin on the palmar surface for the same reason the pulp. This is fastened to the bones by vertical septi going through, fascial septi in different places right here. So this is rigid so you don't slip around when you want to grab something. From a topographical standpoint, this bulge right here is the thenar, T-H-E-N-A-R eminence. This is the hypothenar eminence. Should be a concavity between them right here. So let's see, am I missing anything? No, I think that's about it. Now, when you look, when you go to look at a hand and examine it, you get called to the ER. The sequence of what you do should be exactly the same as what you do for a physical examination any place. First thing you do is you take a little history. Should be a fairly brief history, i.e., when did you get hurt? I.e., how long ago did that injury occur? How long has the bacterial inoculation been there? How chronic is the wound? What happened to you? Did you get crushed between a 2-ton truck and a bridge, or a little hammer blow? Were you lacerated with a clean piece of glass going through a window, or a knife that was just cutting a deer that you caught in the field out? What's the history? How dirty is this wound? How long ago did it happen? Other things of specific relevance, are you diabetic? Are you on blood thinners, etc.? It's not too relevant whether your grandmother had diabetes. That sort of history really shouldn't be related to your attending on the phone at night. But specific things that will affect wound healing and possibilities for infection do make a difference and should be related. Once you've got that brief history, you then look at the hand. You observe first, just like you do in any physical examination. And the hand appearance is fairly typical. I mentioned looser skin on top, which means swelling shows easier here than it does down here. You should have a certain posture of the hand. These combination of phalanges, distal, middle, proximal, metacarpal, the complex of all is called a ray. So this is the index ray, the long ray, the ring ray, the small ray, and by the way, the thumb, I didn't mention, only has 2 phalanges as opposed to the 3. There's a distal phalanx here, a proximal phalanx here, and then right away this is the metacarpal, which corresponds to these. So you have an IP joint, not a DIP joint, because there's only 2 phalanges. So this is the IP joint, intraphalangeal joint, and the metacarpal phalangeal joint here in the thumb. It's different than the other fingers because it's got 1 less phalanx. Now each of these rays, you'll notice they're often depicted artistically and in cartoons as parallel, coming out parallel like this. They really don't. They radiate out like this at an angle to each other, like so. You turn it over, if you push right here in the thenar eminence, you'll feel a bone sticking out, which is the tubercle of the scaphoid, and all of these essentially radiate towards that, just like so. That's a normal configuration of bony architecture of the hand, not parallel like this, where you're at rest like this. And therefore, in looking for fractures, as you observe, a lack of that radiation indicates there may be a malalignment somewhere in the bony skeleton. So you want to take a look at that. Your observation should also consider where is there swelling and edema if there is. For example, have you lost this palmar concavity? Is it swollen on the dorsum? Most of the venous drainage and lymphatic drainage of the hand comes through the dorsum. So most of the drainage of this part goes through and comes along here. So quite commonly an infection or a hematoma swelling here will reflect itself as swelling on the dorsum also. So just because you see it here, you better turn it over and make sure there's nothing going on here too. Make sure you look at both sides of the hand, not just one. So having looked for swelling, open wounds, changes in color indicating vascular problems, capillary fill time. I'm blanching out my fingertip now, it's kind of white. I'm letting it go, turns pink in about 3 seconds or so. That's normal. You want to know if you have normal circulation in each and any place else. Look for blanching, look for darkness, color changes, erythema, swelling, etc. You now should do an examination which is directed towards specific systems within the hand. And you start out with the bony system. As I said, you've got rays which radiate out from a certain area, and you want to know, are you suspicious of a fracture? If the history indicates you could have gotten, I got cut with a knife doesn't indicate a fracture very often. I got hit with a blunt object, got caught in something, got stepped on by a horse, indicates the possibility of a fracture. And you want to know, is there a malalignment? Now there are 2 types of fracture you're looking for, therefore, malalignment and fracture. You're looking for angulation, in which case I'll use this pen as an example. Let's just say there's a fracture site like this. That's angulation. Finger should line up. If it doesn't line up someplace, that's bad. But you can get easily fooled because there's a second type of fracture called a rotational fracture, in which alignment is okay, but you have a rotation of the distal fracture segment like this. Very hard to pick up. And let me see if I can bend this out without breaking it. There we go. Okay. So what you do for that is you first look at the finger and see if the fingernails are in parallel. When you bend them down like this, they should be roughly parallel. The exception to this is frequently the index finger. You'll notice that is supinated, rolled a little bit this way, and that's from a lifetime of pinching against it, and I've stretched out the collateral ligaments here. And that's very common in adults, not in children. So if you see a little malrotation here, that does not necessarily mean a fracture. Now the way to look for this is with the fingers somewhat flexed like this, because if they are straight, let me use the pen for an example again, and it's turned, say, 5 degrees. You may or may not pick this up on the tip, but if you flex it like so, then if you turn it 5 degrees, the number of radians that this rotates, this moves a long distance like that, and you can pick that up. So if you flex the fingers, you will see sometimes what's called scissoring, like this. And that's this long lever arm reflecting a rotation back here, a small amount, but it's magnified by the lever arm here and comes over, so you can see it more easily. So you should always look in extension like this and flexion. If you see scissoring or a malrotation of the fingernails, it indicates an x-ray is required. Angulation is easy to pick up. Now, having looked at the alignment and the configuration and the absence or presence of swelling, open wounds, etc., now what you want to do is you want to examine what's left in the hand in terms of its important functions, and that is both sensation and motor function, movement. And again, this examination is directed towards the ER examination of an injured hand. It is not going to cover niceties such as congenital abnormalities, chronic degenerative abnormalities such as arthritis, rheumatoid arthritis, and the like, which is a whole separate subject which you won't be seeing on an emergency basis very often. So we're going to focus on things you're going to likely to see in the middle of the night that you need to describe to an attending over the phone accurately, so a therapeutic recommendation and course of action can be decided upon without somebody having to run in every night, because that's going to make your attending unhappy. Don't want that. So let's look at motor functions first, and let's start on the palmar or flexion surface, this motor function. You should think of the hand as having two sets of motors. There's an intrinsic set and an extrinsic set. The extrinsic set, meaning it's outside the hand. The muscle bellies are up here, and they motor the fingers and wrist with tendons that cross all these joints, like so. So when something pulls up here, this tends to come down here. So the extrinsic system and the intrinsic system. And we'll do the extrinsic system first. The extrinsic system basically consists of two sets of tendons, the flexor digitorum sublimis or superficialis, either one is proper, and the flexor digitorum, flexor of the fingers, profundus. The profundus muscle belly is a common muscle belly. It's one big muscle belly up here at most people, which pulls, and that tendon, each tendon, there are 4 of them, crosses the wrist joint, crosses the metacarpophalangeal joint, which we talked about here, crosses the PIP joint right here, crosses the DIP joint here, and inserts on the distal phalanx and its proximal end, right about where I'm touching. So when that muscle up here pulls, it will pull down on that joint, like so. And then if it keeps pulling, it will now pull down on the next joint, the PIP joint. And if it keeps pulling, it will now bend the MP joint. And finally, it will be a weak flexor of the wrist, like so, because it will pull on any joint it crosses. But it pulls primarily out here, and nothing else pulls on that. It pulls on this joint, pulls on this joint, and this joint. So you cannot simply say to the patient, okay, bend your finger, oh, profundus must be okay. What you have to do is isolate the function, it's called. So you simply hold the finger like this so the other joints don't move and say, bend that finger. Profundus to that finger is okay. Profundus to this finger is okay. Flexor digitorum profundus to this finger is okay. And to this finger. And the analog to the thumb is the flexor pollicis longus, which again originates in the forearm, crosses the wrist, goes across this joint, stops right here, and pulls down on that one. And you simply hold this and pull it down like that. And it doesn't matter if you remember the names of all these muscles. What I want you to tell me in the middle of the night is he can't bend the distal joint of his thumb. Then I know what's wrong. You don't have to memorize all those names. Nice if you got them, but if you don't in the early part of your career, if you can say to me what's not working, I will be able to interpret that and know what's wrong. So the first thing you do in the motor examination is grab the patient's finger and say, I'd like you to just pull down. And they'll say, oh, it can't, it hurts. You say, well, just move it a little bit. Because if it even moves a little bit, this bone has to be connected all the way up to this muscle. There's no other way for it to bend. So even though he's uncomfortable, if a little motion there means that tendon's not cut. Okay? Now, if we then move down to the next joint, the PIP joint all the way across, that's a little more difficult to examine, because if you say bend your fingers and he does this, or she, that doesn't mean that the superficialis is doing it. Superficialis, flexor digitorum sublimis or superficialis, originates in the forearm, crosses the wrist joint just like the profundus, crosses the MP joint just like the profundus, crosses the PIP joint right here, and stops right here, splits into two, and inserts in the bone right here. And the profundus goes through that split, so-called chiasm of Campere, C-A-M-P-E-R-E. So there are two tendons potentially which can bend this joint, therefore. The profundus crosses it, so it'll bend it after it's bent this one, and the sublimus will bend it, but will not bend that one. So you have to figure out how to isolate that motion, so you know which is doing which. Because if you make a fist and everything bends, it doesn't mean the sublimus isn't cut. So the sublimus, as opposed to the profundus, remember we said the profundus has a common muscle belly up here. Sublimus has an individual slip going to each finger, 4 of them. So what you do is you grab the patient's hand, and you have to put your thumb on the back, and you pull down so the DIP joints, this one, let me get this set up, is hyperextended, like so. That means I am holding the profundus tendon, which crosses this joint out to length. It can't bend because I'm not letting it. See it right there? So then I say, okay, bend this finger. You notice the only thing that bent was this joint. This one's not pulling because I'm keeping that muscle from pulling. That means that's a sublimus motion isolated. The only thing that's moving is the sublimus. And if that's okay, the FDS, flexor digitorum sublimus, to that finger is okay. Same thing on the index. See, I'm holding these out hyperextended. And the hyperextension has to be across the DIP joint. That's the profundus. You're holding it out to length, it can't pull. So now, see, that's not bending out here. I'm not letting it. Ring finger, same way. See it? Now the small finger's a little bit of a problem. Watch. I'm going to hold all these hyperextended. I can bend that one. See it? That sublimus is okay. Let me show you on my other hand. I'm going to hold all these hyperextended. I can't bend that one. I'm trying my hardest. About 15% of people either have a rudimentary or absent sublimus to the small finger. So if you do the sublimus test and this one doesn't work, it doesn't necessarily mean it's lacerated. I got it on one hand and I don't have it on the other. I was just born without it. Surgeon anyway, lucky me. So that's a little bit of an exception to the rule. The others are easy. So you test the profundus, bing, 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 thumb. You hold the profundus out to length, hyperextending the DIP joint, like that. You're going to need a fulcrum in the back to do it, works better. Bend down, sublimus is okay. So now you've tested the extrinsics originating in the forearm, going to the fingers for all the fingers and the thumb. Now there's two more sets of extrinsics which are useful here, and those are the ones that bend the wrist. Now all of these bend the wrist. Remember we said they all cross the wrist joint. So if you keep pulling these fingers down, eventually you can pull the wrist up with those tendons. The profundus and the sublimus all will secondarily bend this, not very strongly. But you'd like to know if the wrist flexors are okay too. Flexor carpi radialis comes from down your forearm and inserts right at the base of the index metacarpal, right here. And you can find it, it's that little band you feel right now. Here's your pulse right there, and it's the one just to the ulnar side of it, this big tendon when I'm rolling my finger over right here. And you simply say to the patient, okay, bend your wrist up, hold it against resistance and feel it. And you feel a bowstring going across there. You can feel it tightens up. For the ulnaris, which is this one right here, my finger's rolling over it now, it comes down and inserts at the base of the fifth metacarpal right here. So you have them pull up and you feel right there, bowstring. So if you got a cut across here and you wonder if they've cut that, the fact that they can move the wrist up doesn't mean they haven't cut those two or one of them, because there are other tendons that can cut it. So you put on a sterile glove, you ask them to pull, and just put your finger in the wound and see if you can feel that bowstring. If there's a bowstring going across here or across here, that means this bony attachment is still attached to the muscle that pulls it. Otherwise, the tendon is cut and snaps back. You won't feel anything in there. So it's the fact the patient can flex his wrist doesn't mean the wrist flexors are okay. You have to specifically examine for them. Now, the secondary way of doing it, which is a little complicated, is this flexor carpi ulnaris not only pulls it in a palmar direction, but over in the ulnar direction like that. And there it is. Patients have difficulty following that direction in the ER. You can try it. Same thing with this, flexing over to this side. But it's easier just to flex against resistance and feel for it, I think. The last thing you'll see is right there, the palmaris longus. This is the most superficial flexor, comes down from the forearm, inserts right here into the fascia, has no important function at all. It doesn't matter if it's cut, and about 15% of people don't have it. It's not a bad guideline, however, because you can usually feel that in most people. The flexor carpi radialis is the next big tendon over right here, and between the two of them, here's flexor carpi radialis, pars majoris longus. That's usually where the median nerve is. So if you want to numb the median nerve, that's where you give your injection, just as a sidelight. So those are all of the extrinsics on this side of the hand, originating in the forearm. Now you have to think about the intrinsics on this side of the hand. And the intrinsics consist of the lumbricals, of which there are 4, 1, 2, 3, 4, each of which originates on the flexor digitorum profundus on its radial side. It's attached to the tendon and inserts across the MP joint into the extensor hood. The intrinsics, therefore, cross the MP joint, where my finger is going, and go into the extensor hood here. That means moment of force, when they pull, they bend the MP joint, but they extend the IP joints because they're pulling on the extensor hood here and pulling down on the MP joint here. So the way to test, though, and their secondary function, by the way, is to abduct and adduct. So you test both. And the way you test that is you simply say to the patient, keep your fingers straight and wave bye-bye. That motion is done by the intrinsics. And if you want to test abduction and adduction, you must put the hand on a flat surface like this. Ask the patient to spread their fingers out like so, and bring them together like so. Doing it against resistance, I'll get my hand out of your way, against resistance is even better, but the problem here is there's one finger that's not being tested when you do that. And if you look at it carefully, you'll see the long finger isn't moving. So you got to specifically say to the patient, now slide that one back and forth, like so, to test that one. Don't have to do that for the other fingers. Now, the reason you do it on a flat surface like this is that the extrinsic flexors, these guys from here that we just talked about, the sublimis and profundus, at the angle they approach the fingers are secondary adductors. They pull the fingers together. And the extrinsic here are secondary abductors on the angle they insert. They tend to spread like this. And you can tell that because if you put your hands like this and you try to make a fist and keep your fingers apart, watch how difficult it is. See, I'm trying to keep them apart. And as you come down, you'll start feeling the muscles in here. I can feel them now really tightening up. You can see those muscles are tight. That's the intrinsics trying to keep them apart against the pull of the extrinsics pulling them down. So the normal relaxed pull, if you just relax, brings them together as you come down. You have to actually force them apart, and vice versa here. If you want to extend, the normal thing is for them to pull apart. If you want to keep them together like in a salute, pull your fingers together, you can feel the muscles inside your hand here tightening up right now. So the patient will say, oh yeah, I can spread my fingers apart, but that's being done by the tendons coming from here. You got to put them on a flat surface so you are neither flexing or extending, then the intrinsics are the only ones doing this. So you spread them apart, pull them together, and wiggle this one, and you've tested them all, and you wave bye-bye, just like that. Now the other intrinsics in the hand are the hypothenar muscles, over here, and the thenar muscles here. There are 3 of them in each place. And it's hard to remember these names. There's a nice mnemonic. They're in alphabetical order. A, F, O. Abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, right over here, from outside to inside. They are all motored, innervated by the motor branch of the median nerve, which is right about here. If you take the ring finger and passively flex it down to where it touches the thenar eminence right here, in almost all people, the motor branch will be within a ½ centimeter of that where it enters. So lacerations in that area, you must specifically test for motor function here. And the way you test that is not to have the patient come over in a pose like this. That's commonly done. But that'll fool you because there's another muscle called the adductor, ADD, adductor pollicis, adductor of the thumb, which originates on the 3rd finger metacarpal, comes across here, inserts right about here, and pulls it across this way. So if the patient can fool you by coming across and touching, that's not opposition. Opposition is best tested, what's called palmar abduction, by taking the thumb in a palmar direction out like this. See it? Rather than trying to touch something. That's a pure median nerve function. But if I turn it supine like this again and lift up, say, I want you to salute, now lift your thumb up and touch my finger. And you will see this muscle right here contract. Push against me. See it contract right down there? That's a pure median nerve function. That's the short abductor I talked about, abductor pollicis brevis, right there. And it's innervated by the motor branch, which passes across like this through the 3 muscles. the opponens, the short flexor, the abductor. So the last one it innervates is this. And if that works, if they push up against your finger and you can see that move right there, then the likelihood is the innervation all the way across here is okay, because it's like a string of Christmas tree lights. It's in series. If this one's out, these are usually out, unless there's just a little cut right out there that got specifically that branch, pretty doggone rare. But if you got your motor branch, all three of them will be out, but this is the easiest one to test. So to test intrinsic function here, you don't ask them to oppose. That can be inaccurate because the little innervations to the other muscles I told you about. You ask them to palmar abduct like this. Let me do it in profile so you can see it out like that. Against resistance is even better. Push against my finger. There it is. You can see it. You got it. The equivalent over here, it's also AFO by the way, abductor brevis, flexor brevis, opponens of the digiti quinti, fifth one. Not as important to have that function, and you just ask them to pull up and you can feel it contract like that, or even spread against your finger, because it's not as important as this is. It's good to check it out though. So now you've tested the intrinsics in the hand also. So we've done the extrinsic system, we've done the intrinsic system, and now we need to do that for this side of the hand also. And again, there are extrinsics. There are muscles up here in your forearm that cross the wrist, cross the MP joint, and go into the extensor hood and into the various bones here and straighten things out. Now the most important reason you want to be able to extend, of course, is so you can grasp. The most important function of the hand is grasp, but if you can't extend first, you can't get around anything much. You can get out to about here just at rest based on tension of the tendons. So you want to try to preserve this, you can, but the far more important function to preserve and pick up is loss of grasp like this. Anyway, the extrinsics. Again, there's the extensor digitorum communis, the common extensor of the fingers, which originates up here in the forearm. Tendons cross the wrist, and this is a single muscle belly, just like the profundus is, which splits into four. The EDC, extensor digitorum communis, which comes across the wrist, crosses the MP joint, and then goes into the extensor hood here, and there's the sagittal bands go around. It's a yoke-like mechanism. It does not insert into the bone, but goes around the proximal end of the proximal phalanx, joins the volar plate, so when it pulls, it straightens that joint, pulls it up like this for each one. And the thing that'll fool you here now is you have two other extensors which are extrinsic to the index and the small, the extensor indicis proprius, the proper extensor of this finger, and the extensor digiti quinti, small finger, goes to here. They are independent muscles, and they also extend that joint. So simply lifting up doesn't tell you if all of them are okay or not. So the way to test these, again, is to ask the patient to hyperextend those joints from a flat surface. I'll show you why in a minute. Because the fact that the patient can straighten his or her fingers doesn't mean that the extensor here is okay straightening them out, because it does go across here and straighten these joints also by entering the extensor hood here and inserting just distal to the IP joint. But you remember we said the intrinsics also cross this joint and flex it, but then they straighten these by going to the extensor hood also. So you can get straightening of this joint and this joint from your intrinsics or your extrinsics. They both will do it. But the isolated function of the extensor digitorum communis, nothing else extends the MP joint. So you want to know if they can lift their fingers up off the surface, and in profile that looks, assume I'm laying on the surface here, I'm lifting them up like this. Say, lift up your fingers right here. And if that joint straightens out, the extensor digitorum communis is okay. Or if one of them doesn't, then it's not okay to that finger. But nothing else lifts that up. These are straightened by two different systems, so it can fool you. Now the problem remains. We have a specific extensor of this joint, the extensor indicis proprius, and a specific extensor of this joint, the extensor digiti quinti. How do you know if one of those is cut? Well, what happens is, you again, just like when you tested the profundus, you take the extensor digitorum communis out of the picture. Make a fist. Now, that muscle is pulled out to length. It cannot pull back unless you let the fist go. Now you say to the patient, now point your finger. See me lift? I can still lift that joint up, even though this is being held out to length, because there's a separate tendon doing it. And sometimes I can show it. Yeah, there it is. It comes across the finger and goes across obliquely. See it right there? Going across. Goes across like this. So you say to the patient, make a fist, now point. Make a fist, now lift up your little finger like you're drinking a cup of tea. And that's independent motion while you're holding these out to length, so it can't be making that motion. And once you've tested that, lifting them all up, and this, then all the tendons that go to these that are extrinsics have been tested. That leaves you a couple of others. There are extrinsics going to the thumb. There are two right over here in the first dorsal compartment, and they are your snuff box, it's called. There's the extensor pollicis longus coming across here, the abductor pollicis longus, extensor pollicis brevis going across here. There are two of them, and in between is your snuff box right here. You commonly see it. The distal end of the radial artery, by the way, goes right in there. And these tendons here insert here and allow you to pull out like this and up like this. This extension is the extensor pollicis longus, which is this one coming right across here, but the problem remains that you have extrinsics going into the extensor hood that do the same thing. So the question is, which one's doing it? Well, you can do it in the fancy way, because as these contract to do this, usually it pulls across like this also. The easier way to test this is simply say, go into a hitchhike position and feel for this bowstring and that bowstring. And if they're both there, you're okay, because they're attached to the muscles and going across this joint. If you want to test the extensor pollicis longus specifically, that's this one right in the front here, it comes across here, goes across all these joints and extends the IP joint out here like that. But so do the intrinsics. So that can fool you, which one's doing it. But this is the only one that will lift the thumb up like that. So if you put it on a flat surface, say lift your thumb up, that's the one that's doing it. You can feel it tighten, right? See my finger move right there? I'm lifting it up in that direction, like so. That's the only one that does that. No other tendon does that. So you test the extensor pollicis longus by going on a flat surface and doing the opposite of palmar abduction. You lift up away from you. You can feel it move right there. Now, that leaves you on the extrinsic system only two others. Actually, there's three others, excuse me. Extensor carpi ulnaris, which is an extensor muscle up in your forearm, comes down here, crosses this joint, and inserts at the base of the fifth metacarpal right here, lifts you up and pulls you that way. And there's the extensor carpi radialis longus and brevis, and those are almost impossible to examine separately. They're in the same compartment. One inserts at the base of this metacarpal, one inserts at the base of this metacarpal. They serve to lift you up in a radial direction. And it's the same as how you tested the wrist flexors here, the wrist extensors. You know they're right here. You say, pull up against me, and you feel there's a bowstring. You can feel tight tendons right across here. If it's cut anywhere, if the attachment of the muscle to the bone is cut, then you won't feel the bowstring because this is retracted. Same thing over here. You feel for this right over the head of the ulna, right here at the base of the fifth metacarpal. Say, pull up against me, there's the bowstring. Having done that, you've now tested all the extrinsics and intrinsics on the extensor surface. So your motor examination is pretty much done. Now the question is, you've got to do a sensory exam. And the most useful thing for sensory exam is something called two-point discrimination. This is a little caliper, which I use for it. I've carried this in my pocket for over 30 years, haven't lost it so far. You don't have to have one of those. If you don't happen to have one, you simply don't test and say, do you feel this? Because there's qualities to sensation. It can be normal, it can be partially injured, it can be completely gone, and you won't pick up the fact that there's a partial injury unless you're testing something more quantitative. Two-point discrimination allows that. If you're missing one of these, what you can do is take a paper clip, simply open it up so you got a little U-shaped piece of wire like this, take a little ruler that most ERs will have, put it 4 or 5 millimeters apart, and test two-point discrimination. So let me set this. For most adults, if the normal two-point discrimination, the ability to tell 1 versus 2 points, should be about between 4 and 6. So let me just set it at 5. And you can tell what the patient's normal is by testing their uninjured hand. Now you recall we said we have a radial and ulnar digital nerve on each finger. So to test it, what you have here is you have a digital nerve that comes right across this metacarpal from the median nerve, goes right here and out here and gives you a feeling on this side. You have a common digital nerve comes here, splits into 2 and gives you a feeling here and here. Another common digital from the median nerve, in most people comes here, splits into 2 and gives you a feeling here and here. And the ulnar half of this and the small finger are usually innervated by the ulnar nerve, which has a proper digital that comes here and a common digital comes here and splits into 2 on almost everybody. And really what you have to do is not figure out which is which. You simply got to test each side of both fingers. Now, when you test, you show the patient, I'm going to touch you with this, do it on your finger. See, it doesn't hurt. It looks sharp. They're afraid you're going to stick them, all right? And you must test in this direction, not across in this direction, because then you're testing one side and the other side at the same time, two different nerves. To isolate a nerve, you must test like this. And you must tell the patient, look away. Do not look at what I'm doing. Show them on their normal hand first, and you can see, oh yeah, you're normal for the index is 5 millimeters or 6 or whatever it is. Depends on their age, depends whether they got diabetes, if they have big calluses or not. You can find their normal on the opposite hand. Say, okay, you feel 1 or 2. Do you feel 1 or 2? And repeat it a couple of times, 1 or 2, 1 or 2. And you do that for each finger, 1 or 2, 1 or 2, 1 or 2. Same with the thumb, 2 digital nerves there also. And you can actually palpate those digital nerves. Here's the head of the metacarpal, that bone there. Comes across here, and if I'm rolling my finger right there. Let me see if I can zoom in and show that to you. I'll get this a little close-up, it's always fun. So the nerve comes across here, right about here, and I'm going to press down against the bone and roll my finger back. Let's see if we can see something snap underneath it. Bing. I don't know if you saw that. See it just proximal to me, that little motion right there. I'm snapping right over the top of it. And same thing over here. You can actually feel them. There's that one right there, just snapped under my finger. Now it runs right here. And the reason it's good to know that is if you want to do a digital block, it's easy to get these. You put it between the fingers. Hard to know where this is, so you can actually feel it ahead of time. Just stick your local right there. Useful thing to know clinically. All right, let me zoom back out. So, two-point discrimination is useful. Just touching them isn't so useful. And you got to be careful you don't move them, because they'll get proprioception and say, oh yeah, I feel the movement. So make them look away, test for 1 versus 2. And it's a lot to record, because you've got 10 measurements then, right? It's a lot to say, well, this one's 2, that one's 3. The easiest way to record it in your chart, if you're in a hurry, is slap your hand on a piece of progress paper. Just trace your hand out like this, zoom, 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 and write 3, 5, 7, 8, 10, 5, whatever it is for each one, just write it next to it. Saves you lots of writing time. And you can do it in 2 seconds that way. So you must test all of those. Now, there are other nerves in the hand worthwhile testing. The dorsum of the hand is innervated primarily by the radial nerve. Radial sensory branch comes down your forearm, exits from underneath the brachioradialis tendon at the junction of the distal and middle thirds of the forearm, right about here, comes up on top, runs here, splits into branches that go to this skin, and innervates you about out to here in most people, right here. And you simply test that by saying, do you feel me or not? There's no standards for what normal sensation is. Now, this is not functional skin. If you lose this feeling, your hand works just fine every place else. It's not really important if you scratch yourself there and feel it. The problem with missing a dorsal sensory radial branch injury, a laceration somewhere in through here, is it's notorious for forming very painful neuromas, which can actually be very, very disabling to the patient. I've had a patient who couldn't even button their sleeve over, it was so tender. So if you have it, the best way to prevent a neuroma is to fix it. So you want to know if you have loss of sensation in here. This part is innervated by the dorsal sensory branch of the ulnar nerve, which comes out more distally. Remember I said this one exits onto the dorsum about the junction of the middle and distal thirds, right about here. This one wraps right around the neck of the ulna, which is right, you can feel the head of the ulna here, and then gives you a feeling right in this area. Not as notorious for neuromas, not as important to find out and fix. Okay. So having done that, you've pretty much tested all the sensation of any consequence in the hand and all the motor function. Now the issue here is it has taken me almost 50 minutes to describe that, and therefore the assumption might be that it will take 50 minutes or so in the ER just to do an examination of an injured hand. But if you do it in a systemic fashion like I just told you, even if you don't know all the names, you test the functions and can tell the attending on the phone what function is absent. The attending can immediately translate that into what anatomic structure is injured and can help you as to whether or not we need to go to the OR tonight, tomorrow, what do we need to do. So let me show you how that goes. Let's assume, for example, that a patient comes in who is upset over something, boyfriend left her, whatever, and has decided to kind of injure her hand or his hand. Take a knife, cut all the way around the wrist, right here, and then whacked it with a brick too, so it's swollen. So now you could possibly have it, based on history, you have a laceration that's extensive here that can involve any volar or dorsal structure, and you have a blunt injury that could involve a fracture. You got the history. Okay, otherwise healthy person except maybe a little upset. So you look at the hand, and you have a swollen hand here, but all the rays look like they're coming from the same place, originating at the same point on the palm, which is a tubercle of the scaphoid. Don't see any malalignment. You see let me just bend your fingers down. Fingernails look like they're lined up in parallel except this one, but that's frequently rotated that way anyway. There's no scissoring when you passively flex down. Probably no fractures, even though it's swollen some, okay? Now you're worried about this laceration. Could have gotten tendons, could have gotten nerves, could have gotten arteries, could have gotten all of them for all you know. So you first look at the hand. Nice and pink, normal capillary fill every place. Probably no major vascular injury, okay? And now you want to know if the motor function is intact. So I will first test the profundus, which you recall flexes the distal joint. I'm going to hold it. Bend your finger down just a little bit. Thank you very much. Bend your finger down. Bend your finger down. Bend your finger down. Can you bend your thumb same way? Thank you. All the profundi and the flexor pollicis longus are okay. Now I'm wondering about the superficialis, flexor digitorum superficialis or sublimis. And I will hyperextend the profundi at the distal joint and say, bend your finger. Thank you. Can you do that one? Same thing here. I know it hurts a little bit, but just do it once for me. Thank you very much. Small finger. Okay. All the sublimis on this hand is okay. Remember, on me, the other hand, it wouldn't be. So I've done that. Now the intrinsics, right? Okay. Now I've got your hand on the table here. See if you can just slide them apart. Thank you very much. Now while and bring them together. Thank you. Now, can you slide your long finger back and forth? Thank you. All the intrinsics are okay. Just wave bye-bye for me. Secondary function. Flexing here, extending here. They're all doing the same thing. Intrinsics are okay. They're innervated by the ulnar nerve. Means the ulnar nerve's probably okay over here too. Now, I wonder about these. Could you have done something to that motor branch or the median nerve? So, salute. Thank you very much. Now lift up your thumb and push against me. Opposition. That muscle contracts. Motor branch is okay. All these muscles are okay. All these muscles are okay. So what does that leave us? Leaves us extensors. Lay flat, please. Now, can you just lift up your fingers? I am hyperextending all those joints. Extensor digitorum communis is okay, but I don't know if the proprii are okay. So can you make a fist for me? Now just point. Thank you. Indicis proprius, okay. Point little finger. Okay over there. Digiti quinti, okay. Make like you're hitchhiking. Really pull. Okay. I feel tendons here. I feel tendons here. Can you lay your flat? Lift up. Extensor pollicis longus, okay. So the two sides of the snuff box are okay. Now just lift your wrist up against me. I feel that right here. This is extensor carpi radialis longus and brevis at the base of this finger and this finger right there. Pull hard against me. I feel that bowstring there. Carpi ulnaris, okay. Pull against me here. Flexor carpi radialis, flexor carpi ulnaris, okay. All right? So I've tested all the sensation and all the motor. Everything's been tested, except now I got to do two-point discrimination. Didn't test sensation, my mistake. Now, I'm going to touch you with this. Let me show you on me. It's not going to hurt, see it? And I want you to tell me if you feel one. You got to look away while I'm doing it. Feel 1 point or 2 points. I'm going to change it from time to time. So, 1 point or 2. What do you feel now? Is it 1 or 2? How about here? How about here? How about here? And you do a couple of times on each, right? And when you finish that, you test for light sensation in the radial nerve distribution here, dorsal. You feel this? Oh, good. You feel this? Okay. Now I've finished everything. And it took me less than 2 minutes. So a full exam, despite the fact it takes 45 minutes to discuss and describe, really can be done in just less than 5 minutes when you get used to it. It should be fairly easy. Patients will sometimes say, oh, I can't do that, it hurts. You don't have to make them go through the whole thing. Just say, just pull against my finger a little bit. If you feel some pull with that right here, if they don't want to go through a full motion like that, then the tendon has to be intact. So it doesn't have to be a full motion to prove it. So the point of this lecture is this. It looks like a confusing exam. There's a lot of anatomy in a small area that can be damaged. You don't have to memorize, at least early in your career, all the names and all what they do. You have to memorize the functions that are lost that you have to test. So you test each function, look for abnormalities in appearance and alignment or circulation, and once you've tested each function, the names will come to the attending when you call them up and say, you know, I've got a patient with a laceration on the palmar surface of her right hand at the distal palmar flexion crease, and 2-point discrimination is normal in all fingers, except on the index finger. 2-point discrimination on the radial side is 10 millimeters. Every place else it's 5. And when I test, the patient cannot bend the DIP, and when I hold other fingers in hyperextension, cannot bend the PIP, but bends the MP. And the attending will say, aha, there's a radial digital nerve lacerated The flexor digitorum superficialis and profundus are both lacerated. We need to fix that. Here's what we're going to do. They will know without you giving them the names. That's not the point of this lecture. You need to tell them what's not working, and then you got it. So I hope that simplifies things. If you have any questions, I'd be glad to discuss it. Thanks very much.